Hi, my name is Jenna Aziz, and I'm an integrated cardiothoracic surgery resident at The Ohio State University. I'm here to present TSRA's 1-minute CT consult. This month's CT consult is you have a 59-year-old female who was discharged to a skilled nursing facility with a tracheostomy that was placed about 1 month ago. She presents to your hospital's emergency room with concern over blood in her tracheostomy tube. What's our differential when we hear this? So we have our less bad, so bleeding from our surgical site, concern over suction trauma, mucosal injury, tracheitis, bleeding from granulation tissue, or potential alveolar hemorrhage. Our very bad, though, would be a tracheoinnominate fistula. So you go down to the emergency room and you start to see pulsations from the ET tube, or from the tracheostomy site. What should your first gut instinct be? First, you should try to overinflate your cuff. You want to try to temporarily tamponade any bleeding that exists. Then, you should try to ventilate from above, remove your trach, and intubate. In order to compress the bleeding, you can put your finger in the stoma and pull anteriorly to try to occlude your innominate artery. In the interim, you should attempt to get your patient to the operating room. In terms of incision, you should utilize a median sternotomy or partial sternotomy to gain access to our innominate artery. You're going to need to dissect the thymus and retract the brachiocephalic vein, and then you're going to need to achieve proximal and distal control. At this point, you should attempt to ligate the artery. There are various methods of repair you can consider. As I said, you can just perform simple ligation, you can perform resection of your innominate artery, you can try to directly repair the fistula or the defect, and then you can try to bypass the fistula with graft. For fun facts, timing of bleeding after tracheostomy is incredibly important when considering your differential. In the first week, your most likely cause of bleeding would be suction trauma, tracheitis, or light bleeding where you made your incision of your surgical site. If you do have a tracheoinnominate fistula, it has been documented to have incredibly high mortality, almost of approximately 100%. Predisposing factors to a tracheoinnominate fistula can include prolonged intubation, so greater than 3 weeks, high cuff pressures, a poorly positioned tracheostomy, i.e. one place below your fourth ring, a high writing innominate, sepsis, hypotension, or prior radiation to this area. And then if you have certain medical comorbidities, such as diabetes, steroid use, or malnutrition, you might be more predisposed to the formation of a tracheoinnominate fistula. Thank you for listening to this month's 1 minute, or more like 3 minute, CT consult.